Today is our second day. We had some more than 30 to 35 sessions yesterday itself, and today also we have some 20 to 25 sessions today. Today's first session is something regarding ABC of diabetes, that is A1C, blood pressure, and cholesterol. So some topics related with these common like issues. So first session will be chaired by two eminent doctors from Kerala. One is Dr. Sibi NS, who is the professor of medicine, Medical College Trivandrum, and he is also my teacher. And another is Dr. Prashant Shankar, my very good friend and my dear colleague. Dr. Prashant is the consultant physician, Muthoot Hospital, Pathanamthitta. So over to you, chairs.
And welcome all to the second day of the Diabetes Today 2020. And as in yesterday, we are going to have an excellent academic feast. And the first topic is by none other than Dr. Robert Mathew. He is a well-known neurologist in Trivandrum and Kerala. And he is going to talk on diabetic neuropathy, a real headache for all physicians. And Dr. Robert Mathew is a professor of neurology and consultant neurologist in Kerala. He is the director of Anugraha Neurocare Center in Trivandrum. He was professor and head of the Department of Neurology in Government Medical College, Almira. He was a very wanted teacher for all students. His interest is in dementia especially, and he did his fellowship in dementia at Neuroscience Research Australia. And over to you, sir.
Thank you very much, Professor Gopi, for those kind words of introduction. And I thank Dr. Sabi for organizing such a wonderful conference and giving me this opportunity to discuss something about peripheral neuropathy in diabetes in the morning session itself. So the heading was that management of peripheral neuropathy in diabetes is a nightmare. Actually, it is, if you it is no more a nightmare. It's all well standardized, and there are definite guidelines. You just have to follow one of them, and it will be easy. That's a list of the various neuropathies in diabetes. So we'll be dealing only with the first one, diabetic sensory peripheral neuropathy, or primarily a small fiber neuropathy. This is what we are going to touch upon in next 10 minutes. These are the other ones. You can have diabetic autonomic neuropathy. You can have mononeuropathy in diabetes. You can have radiculopathy, polyradiculopathy, etc. By and large, the commonest in diabetes is the distal sensory peripheral neuropathy. It's also called a glove and stocking type of neuropathy. And it is basically due to small fiber involvement. So it's also called small fiber neuropathy. And this is the topic for today's discussion. This is the pattern. It can be just a stocking involvement or a glove and stocking. Quite often we see this pattern where there is just a stocking, and once in a while we do see the glove and stocking also. Just to touch upon, there will be hyperglycemia, which triggers multiple events. Finally, there will be nerve injury, and from the injured nerve there will be abnormal discharges, and this will result in diabetic neuropathic pain. So, happens in diabetic sensory peripheral neuropathy. Of course, other factors also play in, like hyperlipidemia also can lead on to oxidative stress, and also trigger some cascades, and they also add. Just about the investigation of patients, the diagnosis of diabetic neuropathy is based solely on and examination. You don't need to go for investigations. Objective confirmatory testing is used in research setting or as part of diagnostic workup of patients with atypical clinical presentation. So by and large, you don't need a detailed investigation for patients with diabetic sensory. So some important points that you have to remember about small fiber neuropathy. In small fiber neuropathy, the physical examination can be normal. So that's very important. So you may think that patient is say, inappropriately complaining because there may not be sensory loss, then there may not be paresthesias. Even nerve conduction study can be normal. Remember that. We consider nerve conduction gold standard in neuropathy. Small neuropathy, the gold standard is intraepidermal nerve fiber density. So this is by doing a nerve biopsy. It needs a specialized expertise. I'm not aware of a center where this is being done on a reliable way. So in our setup, for all practical purposes, small fiber is a clinical diagnosis. This is a picture which I got from the text only. So the panel B shows the arrows are showing the nerves. Are the nerves in the epidermis, and here the number of nerves have reduced and they have become thinned out also, and this is a nerve branch. So the density compared to B, the density in C is less. So that is how small fiber neuropathy is diagnosed based on right. So more than half of all neuropathies are diabetic neuropathies, and 50% of diabetics, in some studies it is 75% of diabetics have neuropathy, and 50% of the diabetics with neuropathy develops neuropathic pain. So it's a big number. So okay. So basic guidelines for any neuropathic pain approach to treatment. So treatment of neuropathic pain is just pharmacological treatment for all practical purposes. There are other treatment options also which are needed in very rare situations. So it's a pharmacological management of diabetic peripheral neuropathy. Some very things. If you don't follow this, then the management becomes a nightmare. Always discuss with the patient a principle of trial and error approach. Like the first medicine may not work, you may have to go for a second one. Like also the first dose may not work, you may have to increase the dose. So it is basically a trial of doing things. So you'll have to discuss the principle of titrating the drug dosage. Always start with milder ones, the pain, or just to give some relief of the pain. Don't go for a very aggressive treatment in the first hand itself. Start with a very small dose, and so patient may have to come for frequent visits or to have a schedule where you titrate it in advance. But this is very important. It is not like a single prescription and sending the patient off. And increase the dose if the pain relief is inadequate and side effects are absent or tolerable. Don't be focused on the symptoms alone or the pain. Patient is saying no improvement in pain. Don't suddenly increase the dose. See how he is tolerating the medicine. So it should be very slowly. And if the drug is ineffective at high dose, or if side effects prohibit dose escalation, then stop the drug and choose another one. Here also, when you're stopping, remember, if you stop it abruptly, then the pain may come again. So you can go for something like an overlap. You continue with the present medicine and then add the new one. And once the new one has taken over, you can try to reduce the first one. And if the drug has been partially successful, so some relief is still patient is not comfortable, then you can do this. So you can go for combination also once done. So withdrawal I have already mentioned. And you are introducing a new treatment, consider an overlap. After starting or treatment, not weeks, you'll have to review the patient just to see how patient is tolerating it, and then only go to the patient. If a patient has a which is working for him, unless there is a definite contraindication, please don't try to change it. It will be a therapeutic misadventure. Just try to increase the dose, titrate it, and still, if it is not adequate, then you can add another one. Very sorry. So this is just to show. This is just a list of some of the studies. I just want to highlight this part. The outcome. So there is a 30% improvement. Here there is a 30 or 50% improvement. See, all studies 30, 50, 30, 50, 30, 50 like that. So the point which we have to emphasize, or impress upon the patient is that by treatment, we are aiming at 30% relief or 50% relief. It is not like we are abolishing the pain. Second point, it's purely a symptomatic treatment. It's one. The treatment is going to be prolonged. It may be it may have to be continued for say weeks. So if we have a whole set of drugs, so which to select? So we have one group of drugs which are recommended by scientific bodies, and there are other drugs which are found to be of use but not yet endorsed by scientific bodies because of lack of enough evidence to really support it. So this is a list. These are the drugs recommended by AAN, American Academy of Neurology, and this is as per their recommendation. But different countries and different bodies have different. The pregabalin is the one which has lot of scientific support or evidence base as diabetic peripheral neuropathy pain. Which is the best one? So which do you select? This is a very interesting one which I always find as a steady ready reference. So this shows the number needed to treat, and so the lesser the number needed to treat, the so in that way tricyclic antidepressant appears to be very good, and that is true also. The size of these dots, that is how robust the clinical evidence supporting it is. So a lot of studies has been done on gabapentin, pregabalin. Studies on tricyclic antidepressants are not, and that is one of the reasons why it doesn't enter into the guidelines of some of the prominent scientific bodies. This is the next slide. So you have three major groups of drugs. One is convulsants. Second is SNRIs. And tricyclic antidepressants. Three major groups are there. So you can select, you can start treatment from one group, and try to titrate, and if there is not much of relief, you can go for the next group of the three groups. And you try groups and you're not getting result, then you can try combination from within these three groups. So this is basically very brief one, but I think this will be the best one to practice in our daily practice. So three groups are there. So if you're thinking of anticonvulsant, the prototype will be pregabalin. If you're thinking of SNRI, the prototype will be duloxetine. If you're thinking of tricyclic antidepressants, it will be amitriptyline. So one of this, start, titrate, no improvement, try another one, titrate, no improvement, try a combination. It's that, and the patients will have. So this is a little more expected. The voltage gated, and these are the anti-epileptics. So the commonly used ones are pregabalin and gabapentin, and the maximum evidence is for pregabalin. And then you have the SNRI, serotonin norepinephrine reuptake inhibitors, duloxetine and venlafaxine, and duloxetine is easily available. And then you have the tricyclics. Now, I've already covered just one word about the opioids. So opioids like say tramadol, tapentadol should be used only as the third tier. You try single medicines, doesn't work, you go for combination, doesn't work, then only go for one of these opioids. This slide is very see, just to highlight the dose of pregabalin, the effective dose is 300 to 600. Gabapentin effective dose is 900,600. SNRI effective dose is 60 to 120. Just one point. How do you select the drug? Select the drug based on the drug interactions and cost, comorbidities, adverse effects. So cost is very keep that in mind. So this is the dose which we have to try, and I'm very sure that many of us, including myself, doesn't reach this dose in majority of our patients due to various reasons. This is the tricyclic antidepressant, and that's a dose of tramadol. Okay, so that's in a nutshell the major drugs and how to select it. There are a number of side effects. This is actually the placebo percentage of placebo who has side effects, and this is from the patient. So side effect is there, but by and large, you have to start at a very small dose, and if you titrate, then side effects may not be too much. So first line will be pregabalin and duloxetine. Opioids, try to avoid as just highlight one point. Many of the studies, or most of the studies, they don't look at the quality of life. That's very, very important, because this is purely a symptomatic treatment. So even if you don't treat, nothing is going to happen. But if you're treating, make sure that the quality of the life improves. The pharmacoresistant neuropathic pain doesn't get at least 50% relief. And try different at least for 1 month. Then comes a pharmacoresistant one, which is very, very, very rare. If you are strictly adhering to the dose, slow titration, and tweaking, I think 90% of our patients will have good relief just with medicines. Only for pharmacoresistant neuropathic pains, you need to go for interventions, which is not part of this talk. I think I have just covered the important things. Shall I take some questions? How do you exit from this?
Yeah, thank you, Dr. Robert. We will take the questions at the end of the session. Is it okay for you? Or,
Oh, okay.
Dr. Robert, I have a doubt. You
Yes,
said
sir.
90% of the patients will respond to pharmacotherapy. In practice, this is not the truth. I agree that we are
Yes, yes.
not going to the recommended dosages, which is
Correct,
very
correct,
difficult.
correct. And be careful about the cost factor also. Like if you're starting gabapentin, and if you are trying to titrate it to say 1000 milligram per day, it will be easily more than say 50 rupees per day. And they will have to buy it for at least 3 months. So
Okay,
that part
that's
has to
fine.
be considered, and they have to be counseled as regards what they are going to attain and all. Then they may stay.
And with regard to pregabalin, with such a dose, what about the incidence of side effects like increase in sleep, weakness, and all those things?
If it is titrated slowly, 150, 225, up to that is well tolerated. So this is my personal experience. But literature says that even 600 is okay. But I think 150 to 225 is easy. Only thing is you go little slow. Maybe you will increase the dose every 2 weeks or even every month. Okay. Thank you very much, Professor CB sir and Dr. Shabir for this wonderful opportunity.
Thank you, Dr. Robert.
Morning of diabetes today. We had an excellent day yesterday. It is continuing today also. So once again, I thank Dr. Sabir for giving another opportunity. So I will straight away introduce the speaker. Dr. Arun Gopi is a well-known figure. He is currently working as a director and head Department of Electrophysiology and Heart Failure and consultant cardiologist at Metro International Cardiac Center. He had his MBBS from Government Medical College Trivandrum and Kerala and gold medals in medicine, surgery, pediatrics, and ophthalmology. And he was working previously as the assistant professor of cardiology at Pariyar Medical College. He has attained the Youth Investigator Award for paper on mitochondrial mutation in long QT syndrome at the Asia Pacific Heart Rhythm Society in 2012. He is also the fellow of American College of Cardiology and the fellow of European Society of Cardiology. So over to you, Arun Gopi sir, for your lecture.
Shabir and his team at TDRF for this opportunity, and to continue the proceedings, I have been assigned the job to discuss the B of diabetes, that is blood pressure control. I'm just trying to share my slides. I'm pretty sure this august audience does not require any insights into the typical management of hypertension in diabetes. So, but I've taken the liberty on discussing one of the so-called slightly uncommon but difficult to treat scenario in hypertension, that is resistant hypertension. To set the ball rolling for this topic, we all realize that hypertension is simply the single largest contributor to mortality worldwide. In fact, it's not not simply called a silent killer. In fact, the largest mortality is attributed to this disease alone. For every 20 millimeter systolic rise in blood pressure, there is a doubling of 10-year cardiovascular mortality, and it dramatically increases the risk of stroke, hypertension, heart failure, and renal failure. The reason why this is contributing so much to mortality is just because only 50% of hypertensives reach the established target. You look at this figure, simply 30% of hypertensives are 35% are treated but poorly controlled. It's only 1/3 of patients who are treated and adequately controlled. And compounding the factor is the very high prevalence of this disease. In fact, 1 billion is affected and is projected to increase to 1.6 billion by 2025. India is in no different pace. In statistics, hypertension is common across all geographic settings and socioeconomic status. In fact, the prevalence is close to 25%. And as with any of the other cardiovascular disease in India, this tends to affect the younger population, at least 10 years younger than the Western population. That is why we need to really understand and manage this disease aggressively. And one of the difficult scenarios in this subset is resistant hypertension. So, all from the American Heart Association scientific statement on resistant hypertension. By definition, it is defined as blood pressure which remains above the target goal despite concurrent use of 3 antihypertensive agents of different classes, which should include a calcium channel blocker, a renin-angiotensin receptor blocker, either an ACE inhibitor or an ARB, and a diuretic. So all these agents should be administered to the maximal tolerated dose at appropriate dosing frequency. And despite that, if the blood pressure target is not achieved, that is when you call it a syndrome of resistant hypertension. That giving 3 antihypertensives to the maximum tolerated dose and despite that not achieving blood pressure control is uncommon. But that's not what the studies say. If you look at the studies across the globe, the prevalence is close to the tune of 19 to 18% of overall hypertensives that you see in your routine practice. And look at this subset of patients, you realize that most of them have multiple comorbidities. They are elderly, they are diabetic, they have albuminuria, they are obese, and one of the commonest coexisting comorbidity is obstructive sleep apnea. If you look at our scenario, what is the single most common cause of resistant hypertension? You look at this picture, it summarizes the real story. People going to hospitals to get their blood pressures checked, people at home measuring the blood pressure of coffee or an exercise, or at AMS, this way the blood pressure is being measured in proper technique. You can see in this last picture the blood pressure being measured on one arm and the blood sugar being measured on the other arm, and you say that no, the BP is not controlled, we need to increase the drugs that you are on. And this is the major fallacy of diagnosis of hypertension, what we call as pseudo-resistant hypertension. In fact, a poor office blood pressure measurement technique or a poor adherence to the prescribed drugs are in fact the most commonest cause of resistant hypertension in clinical practice. Not to forget the white coat hypertension or the clinical inertia on the physician's part to not titrate the doses to the maximal tolerated dose and thereby not giving patient the maximum benefit of the drugs which he should get. We have excluded pseudo-resistant hypertension. This is the AHA algorithm for evaluation of resistant hypertension in your clinic. It goes step by step. First is to confirm treatment resistance. That includes that you have a clinic blood pressure reading which is more than 130/80 millimeters of mercury and the patient is taking at least 3 or more antihypertensives, which include a long-acting calcium channel blocker, a blocker of the renin-angiotensin system, which includes either an ACE or ARB, and a diuretic to the maximal tolerated dose. Once you have confirmed resistance, next is to exclude pseudo-resistance by confirming adherence to the therapy that has been given. The ideal way of doing this is to do a 24-hour ambulatory blood pressure monitoring, which is definitely going to exclude the effect of white coat hypertension. Step is to assess for secondary causes of hypertension. You're pretty sure of the numerous causes of hypertension. Secondary hypertension, which includes the renal parenchymal disease, is the most common entity. Endocrine causes like primary aldosteronism, Cushing syndrome, pheochromocytoma, paraganglioma, vascular etiologies like renal artery stenosis, coarctation of iota, and obstructive sleep apnea are the commonest causes of secondary hypertension, which need to be addressed before up-titrating the drugs in such a scenario. Next is to understand the magnitude of problem, that is, look at the target organ damage, look at the fundus of the patient, examine for evidence of left ventricular hypertrophy either by an electrocardiogram or an echocardiogram, look at the nephropathic damage the hypertension is caused by looking into proteinuria, the estimated GFR, and the extent of atherosclerosis by looking at the ankle brachial index, which gives a surrogate marker of the peripheral arterial tree. Assessed and worked up your patient with resistant hypertension by excluding secondary cause of hypertension and optimizing his drug regimen. How do you manage this patient in your clinic? The first step is to ensure low sodium diet, which you all know means that the daily sodium intake should be less than 2.4 grams, ensuring the adequate lifestyle modifications in the form of good protein intake, ensuring weight loss, regular exercise with at least 6 hours of uninterrupted sleep. After all this therapeutic lifestyle modifications, then we look up into the pharmacotherapy. The first step is to substitute to an optimally dosed thiazide diuretics, which include chlorthalidone or intepamide to the maximal tolerated dose. So first step is to have an optimally dosed thiazide diuretic. If BP is still not under control, the next step is to add a mineralocorticoid receptor antagonist, that is spironolactone or aspirin, which is seldom used as an antihypertensive in our clinical practice. This is one key message from this algorithm, that spironolactone should come higher up resistant hypertension before we add the other vasodilators. Step 4 is to hit at the sympathetic nervous system again by adding a beta blocker. If the resting heart rates are more than 70 beats per minute, you can add a cardioselective beta blocker like bisoprolol or metoprolol succinate, or you can add, in especially cases of pregnancy-induced hypertension, a combined alpha beta blocker like levetiracetam. If beta blockers are, the next step is to look at blocking the central sympathetic drive by using clonidine or moxonidine. Then step 5 is to add vasodilators. The best vasodilators we have at the moment is prazosin and hydralazine in a dose of 25 mg thrice daily. All of these being titrated to the maximal tolerated dose. If despite all these things, blood pressure is still not controlled, you look at really experimental drugs like minoxidil is not commonly available. And then despite all these trial and error with all the pharmacological agents that we have, if still blood pressure, that's when we really look at some invasive approaches. And one of the invasive approaches which has been studied and was in controversy for some time is renal denervation. This all stems down from the basic understanding that the central driving factor in resistant hypertension is the renal sympathetic overactivity. And the key pathogenic substrate in the renal sympathetic hyperactivity is the renal afferent nerves, which arise from T10 to L2, which arborize around the renal artery and travel via the renal adventitium into the renal vascular territory. And this has been targeted. It is simply what we call renal denervation by using radiation ablation, by using a catheter via the conventional access, just about 4 to 6 2-minute treatment approaches on each renal artery is what is done in renal denervation. And this is an animation of how it's done. It's not a very complicated procedure. Just like any percutaneous intervention in the renal vascular artery, you have an access to the renal artery, taking a catheter through this catheter, taking a specialized device which is able to deliver the ablation therapy through this catheter, get into the renal artery, go across the entire circumference of the renal artery, give about 4 to 5 multiple ablations inside the renal artery, and thereby disconnect renal nerves by getting into the juxtaglomeralar apparatus and driving their excess sympathetic activity. So once you have denervated the kidney, hypertension becomes more amenable for blood pressure control. And we had some fascinating results from Simplicity Hypertension 1 trial, which was the proof of the concept, which showed that it's a very simple procedure, average procedure time of 40 minutes, no major complications, and significant reduction of blood pressure to the tune of about 30 millimeters of mercury. And the response rate to this therapy improves over time. You can see at the end of 3 years, the response rate was close to 100%. And despite having some fascinating results in the first trial, the second Simplicity Hypertension 2 trial, the first sham-controlled prospective randomized study of Simplicity Hypertension 3 was a real disappointment that it did not show any benefit. And so this therapy went into disrepute, but of late, they have modified the catheter, and using a different catheter, they have found some positive results in the denerve hypertension trial and the spiral hypertension of medicine study, and I'm pretty sure renal denervation is going to come back and is going to be one of the best sorted after therapy in resistant hypertension. But that all patients are not suited for this therapy. If there is really resistant hypertension and the patient does not have established renal parenchymal disease with the estimated eGFR being more than 45, and the patient should have a suitable renal anatomy, that at least one main renal artery which is more than 4 millimeter in diameter and more than 20 millimeter in length is an important criteria for doing this therapy in patients with persistent hypertension. We were doing this in our conventional EP lab using the conventional catheters that we have, and we found some good results. But now we are still awaiting the more evidence from trials before using it in all cases of resistant hypertension. So, ladies and gentlemen, respected chairs, to conclude, resistant hypertension is defined as above goal elevated blood pressure in a patient despite the concurrent use of 3 antihypertensive agents, which should include a calcium channel blocker, a RAS blocker, either AC inhibitor, ARB, or diuretic to the maximal tolerated dose. Encountering a patient with resistant hypertension, the first step is to rule out pseudo-resistance that ensures that you have measured the blood pressure correct, you have excluded white coat hypertension, you have ensured treatment adherence. After that, you work up for secondary causes of treatable hypertension and look at the extent of end organ damage. Then, as per the algorithm, go for a stepwise addition of drugs, which should include a mineralocorticoid receptor antagonist, a chlorthalidone or a thiazide diuretic, followed by beta blockers, centrally acting sympatholytic agents, and vasodilators. And when all these pharmacotherapies fail to give us some answer, renal denervation therapy or vagal and afferent blockage is going to be a promise for future. So I'll conclude there. Thank you for your hearing, and I thank Shabir once again for giving me this opportunity, and I'm sure it's a testimonial for our 22-year camaraderie, and I hope to be a part of this next year as well. And I congratulate him to continue his perseverance of continuing his academic dissemination despite all these tough times that we are going to. And I conclude with a moment of prayer for all the suffering souls in this time of COVID and natural calamities. Thank you. Thank you all.
Thank you, Dr. Arun Gopi, for that enlightening lecture. I think an important point which you mentioned was the addition of the mineralocorticoid receptor antagonist. Very often it is an underrated drug in the management of hypertension. Maybe in patients with heart failure, it is given routinely, but in patients without heart failure, just a point. Any questions from the other members? One last question to you, Dr. Arun Gopi. I would just like to ask your opinion about home BP monitoring and ambulatory blood.
Yeah, this
in resistant hypertension or the pseudo-resistant hypertension.
I would say that there needs to be more wider use of home blood pressure monitoring and ambulatory blood pressure monitoring, not only in the field of resistant hypertension, but also in the management of routine hypertension, because a lot of the mismanagement happens because we are relying totally on clinic blood pressure reading. And we all know from trials that the end organ damage or the morbidity of hypertension comes from poorly controlled blood pressure readings, which correlate more with the home blood pressure readings or readings on the ambulatory blood pressure monitoring. They are more definitive than the clinic blood pressure reading, and they should become a part of the evaluation algorithm for all patients with hypertension.
Hello, Dr. Arun. Hello.
Yes.
You said, is it true that beta blockers come only in the fourth or fifth list as an antihypertensive in Indian patients also? Because we are having many patients with increased sympathetic activity with a resting heart rate of more than 80. Do you think we can start with beta blockers in these patients, especially younger patients?
Thank you, sir. That was a wonderful question, a sought-after question. See, we should understand that beta blockers were disrepute as an antihypertensive based on some from meta-analysis from Mersalis group, which actually enrolled maximum trials which had atenolol. And the reason why it went to disrepute was atenolol did not reduce the central aortic pressure sufficient enough to reduce the risk of stroke. But that's not true for all class of beta blockers. We have ample evidence of beta blocker as an antihypertensive agent, as you said, in young hypertensives with a basal heart rate which is more than 80 beats per minute. In young hypertensives, even if you look at the NICE guidelines, they say if the age is less than 55, it is A or B. That is, if the agents are either a RAS blocker or a beta blocker. In all patients with young hypertension, the major driving factor is increased sympathetic drive, as evidenced by a elevated resting heart rate. And in these patients, cardioselective beta blockers, especially bisoprolol and metoprolol, forms a very important treatment arm for these patients. So beta blockers are not in the dustbin as an antihypertensive. It's only that you should carefully use them for young hypertensives and hypertensives with compelling indication like presence of coexistent coronary artery disease or coexistent heart failure.
Thank you, Dr. Arun Gopi. I think we can move into the next session.
Dr. Mathew John is an endocrinologist and at Providence Endocrine and Diabetic Specialty Center, Trivandrum. He did it MDM from the prestigious KEM Medical College, Mumbai. He had over 40 publications in index journals and is a well sought after speaker in many conferences. He is an investigator in phase 3 clinical trials in many clinical trials. He is a good organizer, as evidenced by he was an organizing secretary of ESICON 2017. Over to you, sir.
Yeah, thank you very much, Dr. Shabir, for this opportunity. I'm very thankful that Dr. Shabir is inviting me every year for this program. So I'll be looking at diabetic kidney disease, new targets and new therapies. So just to start off, diabetic kidney disease is the question, because it's very variably defined by different organizations. Basically, diabetic kidney disease is a chronic kidney disease which is attributable to diabetes. It is defined as an estimated GFR less than 60 or a urinary albumin creatinine ratio 30. So, to be definition is that it is defined by a eGFR criteria and also by an albumin criteria. So both criteria are defined either or. That's it. We use diabetic nephropathy almost interchangeably with diabetic kidney disease. But there are some people who believe that diabetic nephropathy is a histological diagnosis. And non-diabetic renal disease may be present in diabetes patients. This have to be differentiated. Yesterday there was a talk, so I'm not going into those details. If you look at the natural history of diabetic kidney disease, you can see how this progresses. You can see first there is an increase in albuminuria for most patients, which later progresses on to a proteinuria. And at the same time, you can see how eGFR behaves. The eGFR, what you can see on the picture is the yellow line, which initially increases. There's a stage of hyperfiltration. And later, the eGFR slowly starts coming down, and which moves on gradually year after disease progression. So in this picture, what you would see is two lines. One is the gray line and one is the black line. So if you identify diabetic kidney disease early, what you can do is to institute treatment, which includes various treatment modalities, which I'll be describing, in addition to control of glycemia and control of hypertension. And if you take care of diabetic renal disease well early, you can see you are able to add around 10 years of life, extra life to the patient, or rather 10 years of dialysis-free life to the patient. So that is the importance of going for identifying kidney disease early in the course of the continuum and instituting treatment. Now, how do you diagnose diabetic kidney disease? I think this is something which does not require much of explanation, but just to give you normal values, the normal protein excretion is around 40 to 80 milligram per day, and the normal urinary albumin excretion is less than 20 milligram per day. And most of the albumin which gets excreted, most of the proteins which gets excreted will include the albumin, the TAM horsefall protein comes from the tubules, and other proteins, which is around 15 to 20% of the total excretion. So when the albumin excretion goes more than 30 milligram per day, or the protein excretion crosses 150 milligram per day, we call it that there is significant or abnormal proteinuria. A urinary albumin excretion of 30 to 300 milligram per day called microalbuminuria previously, and it is now called moderately increased proteinuria. And in 100 milligram per day is called severely increased proteinuria or overt proteinuria. So these are the two terminologies that we use. What we do in outpatient is we have almost during the 24-hour urine protein and albumin. Rather, what we do is something called UACR or PCR. UACR stands for urine albumin creatinine ratio and PCR stands for protein creatinine ratio. So you can see the normal ranges which I have mentioned on the sides. Calculate is a very important part of looking at renal disease, because if you had realized the graph which I showed you earlier, you can see that when you plot EGFR against the time, that is how you realize the renal progression. Because if you are plotting creatinine against time, you would realize the very, very minimal changes in creatinine which may not be realized as the time and the age of the patient progresses. So these EGFR calculators are freely available on the net. And if you're not into the practice of using EGFR, please start using it, because that will guide you in diabetes, choice of antibiotics, the dose of antibiotics, and many other things that you do in clinical practice. Now, once you calculate the EGFR and once you calculate the urine albumin creatinine ratio, then stage the CKD and put the patient in a particular staging. So that is very important, because that will decide what treatment you are going to give to that particular patient. So suppose you have a albumin creatinine ratio of say 30 to 300 milligram per day. Here what you can see is milligram per millimole in the picture, but this stands for 30 to 300 milligram per day. And your EGFR is between 45 to 59. You become stage G3A, A2. So you can always keep this picture in your outpatient department and stage your patients accordingly. Now, how do you get the disease under control? What are the interventions that are effective? So when you have normal albuminuria, your main intervention is glycemia and hypertension. When you have microalbuminuria, your main intervention will still continue to be glycemic control and hypertension, but that is the time to consider using ACE inhibitor, ARB, or the newer drugs like SGLT2 inhibitors. And one proteinuria, again, controlling hyperglycemia and hypertension is important, but all the more important that you uptitrate your ACE inhibitors, ARBs, and always consider use of SGLT2 inhibitors. Now, how does the natural history of diabetic kidney disease behave? So, if you look at UKPDS, I put up the UKPDS data because this is the one data which has started following your patients very early in the course of disease and over a long period of time in a sort of randomized control setting. So 2% of patients every year progress from normo to microalbuminuria and from micro to macroalbuminuria. And at the end of 15 years, 40% had albuminuria and 30% had EGFR less than 60 ml per minute or doubling of serum creatinine. And 60% of those developing kidney function impairment did not have albuminuria, remember that, and 30% never developed albuminuria during the course of study. So this is to just tell you that you should be aware of an entity called non-albuminuric renal dysfunction in people with diabetes. And this is increasingly seen nowadays that we are using extensively ACE inhibitor ARBs for hypertension control. So patients don't go into the proteinuric stage. Now coming to the treatment aspects, very important that with a lot of new molecules in place, we should not ignore the importance of controlling hyperglycemia. You can see in the first picture on the left, the red box, conventional therapy versus intensive therapy in patients with microalbuminuria. You can see that intensive therapy definitely reduced the number of patients who develop microalbuminuria in the UKPDS study. So this is basically a primary prevention of microalbuminuria. And on the right side, what you can see is the systolic blood pressure plotted against number of patients having doubling of serum creatinine or ESRT. Again, you can see that people who are well controlled in terms of the blood pressure less than 135, in fact, had a significantly lower progression of renal dysfunction. So, both for albuminuria and for progression of EGFR, hyperglycemic management and blood pressure management are very important points. Now, come to the role of RAS inhibition. These are two data just to show you how irbesartan, The first one is the IDNT study, the irbesartan trial, and on the right is the renal trial. Just to show you that compared to amlodipine, means irbesartan versus amlodipine, the first trial, and the renal trial, losartan versus the rest in terms of standard BP control versus losartan based BP control, you can see that the percentage of patients with ESRD or the patients of primary endpoint, the patients in the IDNT, both these places you can see that there is a reduction of risk with the use of ACE inhibitor or ARB. So after glycemic control and hypertension control, use of ACE inhibitor of ARB to maximum tolerated or maximum doses is a very, very valuable thing. Now, our knowledge of how drugs behave, the SGLT2 behaves, comes from the EMPOWER outcome study, the CANVA, and the declaratomy in terms of the SGLT2 inhibitors. So although the EMPOWER outcome study was not a trial which is primarily done to renal benefits, there was a significant number of patients in the renal group who had problems, and you can see or worsening nephropathy, new onset macroalbuminuria, doubling of serum creatinine, and first initiation of dialysis. Everything went down significantly with the use of empagliflozin. Now, if you realize this, ACE inhibitor use was found in 80% of these patients. Around 11% of patients had microalbuminuria as macro, and 28% had microalbumin. So you have around 30% of patients in the cohort who had sub-CKD. Now coming to the canvas, again similar data, almost no difference. UACR reduced, albuminuria reduced, regression to albuminuria was more, regression from albuminuria to normal albuminuria was more in the people who were on canagliflozin, and the composite endpoint also reduced in canagliflozin. Here again, you can see ACE inhibitor use is around 80%, and overall CKD is around 20%. Similar data with the declaratomy, which used dapagliflozin, again showing that all the renal composite endpoints reduced in patients who were using dapagliflozin in the declaratomy. So, but overall CKD is only around 8%. So, among the three trials of SGLT2 inhibitors, CVOTs of SGLT2 inhibitors, you can see that 30%, 20%, and around 8% patients had CKD, sizable population. But remember that all these trials were reasonably low patients with renal dysfunction which were enrolled. You can see from the mean EGFR anything more than 70 and the UACR almost less than 20. That is the mean value. So these are all low risk. Now the credence trial comes in. These are the real renal patients that you can see. People with EGFR between 30 to 90, UACR between 300 to 5000, and on stable maximum tolerated dose of ACE inhibitor or ARBs. You can see that the group of patients getting 30% of patients had significant renal dysfunction between 30 to 40. You can see the rest of the distribution here. 4,000 odd patients were tried. So the results are really astounding, or rather fascinating. I should say the primary outcomes you can see significantly in favor of canagliflozin. Zeros in the p-values. If you value p-values, you can see end-stage renal disease of serum creatinine or renal death significantly reduced. Dialysis, kidney transplantation, or renal death significantly reduced. Not only was there in terms of renal, you can see the effects in terms of CV death or hospitalization for heart failure, major cardiovascular events, CV deaths, everything in favor of canagliflozin. So this is again to put forward a point that even in patients with renal disease, the end cause of death is cardiovascular, and SGLT2 inhibitors are wonderful in terms of looking at both cardiovascular and the renal outcomes in patients with diabetic kidney disease. Now it's important to realize that all these trials did in fact use SGLT2 inhibitors along with RAS inhibitors, and they have a significant synergistic effect, RAS inhibitor and SGLT2 inhibitor. And I'm not going to explain each of this, but this is a wonderful sort of mechanistic picture which will help you understand how they act. So before I end my talk, the last 2-3 slides. How do you go around for every patient? Glycemic control, control blood pressures, control the lipids, stop smoking. Start patients on inhibitor or ARB if they have albuminuria of any size, and that is titrated to the maximum possible dose without hyperkalemia. Then you continue to look at whether albuminuria is persisting. If there is albuminuria persisting, you consider the use of SGLT2 inhibitors. So if you have patients who don't tolerate ACE inhibitor ARB, you can still go to use control blood pressure well, start using SGLT2 inhibitors. And the question which is often asked is that does other drugs affect the efficacy of SGLT2 inhibitors? In fact, it doesn't affect. This is the data from the EMPOWER outcome study. You can see the last column on the right, that whether you are using ACE inhibitor or ARBs, whether you're using diuretics, whether you're using CCBs or NSAID, the effects of SGLT2 inhibitors still continue to persist in terms of renal outcomes. Now, after the credence, there's a label change for canagliflozin which should be realized, that everyone diabetic kidney disease and albuminuria is a candidate with more than 300 milligram per gram of albumin is a candidate for the use of canagliflozin. So this is irrespective of your HbA1c, and the dose to be used is 100 milligram. If you top of that, you could increase the dose to 300 milligram. Otherwise, 100 milligram becomes the effective dose in most patients for canagliflozin. When I say new drugs, there are a lot of new drugs. We know that SGLT2, just like SGLT2 inhibitors, GLP-1RA has got a favorable effect on renal disease progression. So that is being studied. You have various other drugs, CCR2 antagonist, CCL2 antagonist, JAK1 antagonist, phosphodiesterase inhibitors. So various things in the pipeline. Allopurinol was once considered, but the Pearl trial, which has put it down. So this is end of my talk. Thank you very much.
Thank you, Dr. Mathew, for that excellent presentation. Any question from the audience?
I will introduce the next speaker, who is none other than Dr. Tejas Shah, who is a vibrant diabetologist and the director of IVA Diabetes Care Center, Mumbai. He is honorary diabetologist at SL Raheja Fortis Hospital, Mumbai, and he also has diabetes care centers at Malad and Andheri. He is also visiting faculty for the Fellowship of Diabetology at Dr. D.Y. Patil Medical College, Navi Mumbai. He is the founder and treasurer of the United Diabetes Forum and organizer, scientific committee and faculty of CDI 2014 till date. So I hand over the session to you, Dr. Tejas.
Thank you. Thank you very much. Big thank you to Dr. Thank you very much. Yes, we are talking. I'm going to talk to you today about primarily two important drugs and their use in diabetes. What we know is cardiovascular disease is an important cause for morbidity and mortality. As you know, all over the world, patients with diabetes are at an increased risk of cardiovascular disease. Prevention of any disease, as you know, requires intervention which needs to be done at a population level, as well as intervention which needs to be done at an individual level. So for cardiovascular disease, primarily, if you are talking about intervention at a population level, it requires lifestyle modification, education programs, etc. But at an individual level, we need to target the risk factors. We need to target therapies, particularly which would prevent the progression of diseases. In terms of cardiovascular disease, it would be drugs like aspirin, so statin, or management of lipids per se. So cardiovascular events are increased from 2 to 4 folds in diabetes. We know that in diabetic patients more than 65 years, almost 68% of deaths are due to coronary heart diseases. There have been enough studies to show that low dose aspirin per se is effective in reducing cardiovascular morbidity and mortality, especially for secondary prevention. But the question keeps on raising primarily its effectiveness in primary prevention. The prevalence of heart disease ranges from 2 to 4% in general population to as high as 55% among patients with diabetes. And almost 25% of the patients with an acute myocardial infarction have diabetes, which has been seen in various studies. Excess risk for cardiovascular diseases can be found in patients with type 1 and type 2 diabetes and pre-diabetes. And overall, the mortality rate for heart disease is almost twice in men and almost 3 to 4 times in women with diabetes. So there have been various causes which are responsible for these changes that we see in patients with diabetes. It could be the hyperglycemia, it could be the hyperinsulinemia, there's the autonomic neuropathy creeping in with duration of diabetes increasing, that is hypertension, dyslipidemia, obesity, smoking, altered metabolism in patients with diabetes, more incidences of cardiomyopathies and heart failures being there in the patients with diabetes, diabetes getting diagnosed late, underutilized evidence-based therapies, which all could be responsible for increased vascular risk primarily in patients with diabetes. Pathophysiologic bases for these increased diseases are many. It could be endothelial dysfunction, the arterial stiffness, the inflammatory changes, the oxidative stress in patients with diabetes, the dyslipidemia, hypercoagulation. Apart from that, lifestyle factors, inactivity, poor diet, obesity, all these things together lead to this uh, problems of diabetes with cardiovascular diseases together. So in way back in 97, as the ADA had recommended aspirin as a primary and secondary prevention for cardiovascular events mainly. But over the period of time, various studies which have been done, studies did show benefits of with aspirin in patients with pre-existing cardiovascular disease and diabetes. There have been some primary prevention trials also done in patients without diabetes also, which showed an improvement, like the HOT trial, the APT, the early diabetic retinopathy studies, which had limited number of patients with diabetes. Duration of study was more than 5 years and showed an 18% risk reduction in patients for non-fatal MI. The physician health study showed almost a 44% risk reduction. But these studies had patients with diabetes in a very, very small amount. The population content for patients with diabetes were less, and there was not enough data to make sure that patients with diabetes for primary prevention really benefited with aspirin here. There have been again theories about the platelet changes that happen in patients with diabetes. Platelet phenotype changes, platelet variation is there. Chronic hyperglycemia leads to non-enzymatic glycation of glycoproteins. There is deficient insulin action or insulin resistance leading to platelet dysfunction. There is impaired response to prostaglandin. And there is other abnormalities like platelet turnover and endothelial dysfunction, which could be there in patients with diabetes. Response to aspirin is again thought to be different in these people. Aspirin, as you know, primarily is working through the inactivation of the COX-1 pathway, and due to the irreversible inactivation of COX-1, the antithrombotic effect of aspirin also lasts for an entire lifespan of platelets. So low dose aspirin sometimes does not show the adequate effect in patients here because the COX-2 pathway is not purely inhibited, and the changes happen through the COX-2 pathway also. And therefore, this question keeps on coming whether the effect of aspirin is equally good for primary prevention in patients with diabetes or it is only for secondary prevention. There are a few studies which have thrown light on this in the last few years. If you look at the ASCENT trial mainly, ASCENT trial was the largest trial done with around 15,000 patients almost, which addresses the question of benefits of aspirin. It used low dose aspirin of 100 milligrams and patients were followed up for almost 7 years, where the primary endpoint was to look at primary endpoint was looking at the myocardial incidence of infarction, stroke, and TIA. At the endpoint, mainly, it did show a difference of around 8.6% versus 9.3% in patients with aspirin. But overall, there was a 50% risk of major bleeding happening in patients on aspirin here, and for more than 40% of the bleeding occurred in the GI tract. So the benefit risk profile of low dose aspirin in the ASCENT trial was independent of the baseline vascular events, but it was thought that the benefits did not outweigh the risk of bleeding per se. There was another paper which came out in 2007 from the ADA-AHA again, recommending that aspirin therapy should be used as a primary prevention strategy in those with diabetes at an increased CV risk, including patients more than 40 years of age with risk factors. But again, following that, there have been few important trials like the JPET trial, that is the Japanese primary prevention study. Again, it was a large study done. It looked at aspirin mainly in patients for primary prevention. Few patients had some risk factors here. The patients were followed up for almost 4 years. and the primary endpoint did not show benefit with aspirin in this subset of patients. The only advantage it showed was in patients above 65 years of age, but not in overall study population. The POPADAT study, which is again a comparative multi-center randomized trial, it looked at 1,276 Scottish adults more than 40 years of age, and it had patients with peripheral vascular disease. Those with the ankle brachial index of less than 0.9 were included, and the combination of aspirin and antioxidants were looked at in these patients, whether they give benefit. And the endpoint, again, it did not show a benefit for primary prevention in this subset of patients. And the hazard ratio and the incidence of events were almost similar in patients on aspirin versus patients who were not given aspirin. So these important studies did not show the additional effect of low-dose aspirin, mainly for prevention of CV events. The current guidelines and consensus regarding aspirin are mainly stratified according to the risk of the patient, where a low-risk patient is somebody who has an incidence of risk less than 10%. A moderate risk is somebody with a risk with two risk factors and a 10-year risk of 10 to 20%. And a high risk individual is somebody with more than 20% risk with multiple risk factors again. So ESC guidelines in 2019 recommends that in patients with diabetes at a very high risk, aspirin of 75 to 100 milligrams per day may be considered in primary prevention in absence of contraindications. In patients with diabetes at a moderate CV risk, aspirin for primary prevention is not recommended. When low-dose aspirin is used, a proton pump inhibitor should be considered mainly to prevent GI bleeding, and aspirin 75 to 100 milligrams may be considered in patients with a history of MI or revascularization, but with a definite evidence of cardiovascular disease on imaging. The ADA-EHA guidelines in 2019 again recommends that aspirin therapy at 75 to 162 may be considered as a prevention strategy in those with diabetes who are at an increased risk after discussing with the patient regarding the risk of bleeding. Well, the AHA in 2019 recommended aspirin to be used at a lower dose for primary prevention of ASCVD for adults between 40 to 70 years of age at a higher ASCVD risk, but should not be at an increased risk of bleeding. Coming to the second important therapy, that is statins in diabetes now. Well, what has changed in the last few years, if you look at the statin guidelines and the statin from 2016 to 19, there have been enough evidences that showed that lowering of LDL cholesterol is the primary factor to reduce cardiovascular events. There is no lower limit of LDL cholesterol reduction. The lower you go is better now, and trials have shown that there is no J-shaped effect for LDL cholesterol again. And statins have primarily proved that they are the drugs which are necessary to reduce this LDL cholesterol and in general to reduce the LDL atheroma accumulation. 6 important lipids which we know: the triglycerides, the VLDL, IDL, LDL, HDL, and ApoB. And typically, the diabetic patients usually have a decreased HDL and an increased level of LDL and triglycerides, which we see. In terms of statin therapy, we have come a long way from the earlier statins. Gradually, we have now come on to more of atorva and rosuvastatin, which are the more safer statins, as we know. They differ in terms of their lipophilic and hydrophilic properties. Some of these statins, per se, the mechanism of action, as you know, is primarily through reversible inhibition of HMG-CoA reductase. They prevent the HMG-CoA reductase conversion here and thereby decrease the LDL, the cholesterol, and cause increased expression of LDL receptors. They're known to have various pleiotropic benefits also apart from the reduction of cholesterol. They're responsible for some amount of platelet activation, endothelial function improvement, macrophages. They have reduced the inflammation. They have effect on collagens, they effect on endothelial progenitor cells, and these pleiotropic benefits are also supposed to play a role in their primarily reduction of cardiovascular events. Prescribe statin or no is a question that comes up sometimes, which is really a question we are not be asking, especially in patients with diabetes. But the question came up because primarily due to certain factors. Way back in when the Jupiter trial came out, this question came out because they found out an increased incidences of diabetes happening in patients who were subjected to rosuvastatin in the Jupiter trial. There was almost a 26% increase incidence of diabetes. But later on, it was seen that with various trials which have been done with statins to find out the risk of diabetes, that the benefits far outweigh the risk that is there associated with it. This is one of the meta-analysis which was done, which looked at various trials and associating the risk of diabetes and statin. In this meta-analysis, almost there were 9 studies which were enrolled here, and there was a small increased risk of diabetes or relative risk of 1.13, which was seen here. Another meta-analysis was done with 13 important large trials. It included the VOSCOPS and the Jupiter also, and it showed an increased incidence of around 9 to 13% for patients with to have diabetes again. This was another paper in JAMA which said that statin therapy is associated with an increased risk of development of diabetes, but the risk is in terms of absolute terms, and definitely the benefits that statin gives in terms of cardiovascular risk reduction are far more superior. And what was seen in the various meta-analysis and the trials, that a patient, 255 patients need to be treated for a period of 4 years to have 1 case of diabetes, and therefore the benefit, that reduction in cardiovascular risk that a statin gives should be, should be considered, and not the risk of developing diabetes. 2020 guidelines for the patients with diabetes regarding statin mentions that for patients with diabetes 40 to 75 years of age with a cardiovascular disease, without a cardiovascular disease, a moderate intensity statin should be used. For patients with diabetes 20 to 40 years of age with additional atherosclerotic disease, in the statin therapy should be initiated. In patients with diabetes at a higher risk, and especially those with multiple risk factors between 50 to 70 years of age, a high intensity statin is necessary. And those with a 10-year risk, 20% or higher, if the patient's LDL target of less than 55 is not achieved, or is still at 70, an additional drug like an ezetimibe should be added. For second prevention strategies, for all patients of all ages, higher therapy should be added, and for patients who do not tolerate intended insulin, the maximum tolerated dose should be used. There are some important studies which have been done for primary prevention studies in patients with diabetes, like CARDS, aspirin, HPS, which all showed a significant improvement. The aspirin did not show, but the other 2 studies showed almost a 37 and 33% reduction in patients with diabetes. There is a patient studies like MEGA, ASCOT, and ALHAT, which again were done, which had subsequent of almost 20 to 25% of the subjects with diabetes, which showed some improvement. The PRO-YT mainly compared a higher dose atorvastatin 80 milligrams versus pravastatin and showed a 25% risk reduction in the acute coronary events in patients with diabetes again. So, in overall, if you summarize, statins should be used more cautiously in patients who are at lower risk. In groups in which the benefits of statins on CV risk reduction is the cautious use of statin is advised. If the statins are used in these low risk groups, restricting their use to those with a least moderate LDL elevation and regular monitoring of fasting glucose seems reasonable. The use of statins should not be withheld from subjects at a higher cardiovascular risk, even if they are prone to new onset diabetes, because their benefits outweigh their risk. And if new onset diabetes develops, statin treatment should not be stopped, but a switch to a more favorable statin should be considered here. So, balancing the cardiovascular benefit of a low dose aspirin for prevention and the bleeding risk must be considered. To examine the risk benefit ratio of aspirin used for primary prevention in adults with diabetes, when low dose aspirin use, a proton pump inhibitor should be advised. For primary prevention, aspirin should not be routinely used in individuals with type 2 diabetes, but should be considered with statins in significant reduction in cardiovascular events, and higher statins per se reduce the non-fatal events in people with established cardiovascular disease, and statins should be considered for all people with diabetes more than 40 years of age. Thank you very much.
Thank you, Dr. Tejas, for that wonderful lecture again. It was very elaborative. I have all the aspects of using aspirin and statins in patients with diabetes. So the message is very clear. Aspirin has to be given in most patients with diabetes for secondary prevention, and you have to individualize the patients for primary prevention of the aspirin. Statin has to be given irrespective of to almost all patients with diabetes, immediately over 40 years, and in less than 40 years again we have to stratify using multiple risk factors. Are there any doubts?
Is there any entity called aspirin resistance, and is it more common in diabetic patients? If so, should we go to other antiplatelet drugs in diabetic patients?
Yes, there is something called aspirin resistance. They have found out that there are some occasions where patients with diabetes do not respond to aspirin in the same manner, and there have been some exact theories for that are yet not known. There have been, and for such patients, of course, you should be thinking about switching over to other antiplatelet agents like clopidogrel is what is recommended.